Good afternoon, everybody. I'd like to welcome you to the latest in our series of webinars, which we've entitled Mass General Answering the Call. And today's program is Keeping Your Family Well During and Post COVID-19. I'm Dr. Britt Nicholson. I'm the Senior Vice President for Development here at MGH. We really have again, a terrific panel for you this morning. And before we start, I'll go over a few housekeeping items. So the first thing is that no microphones or video capabilities are needed to participate in the webinar. And at any point during the webinar, you're able to ask questions anonymously if you prefer, or if we don't happen to get to your question, if you list your name, we can get back to you individually with the answer. You can do that through the Q&A feature that is at the bottom of the screen. We'd like to get through as many questions as possible, so if you can keep the questions as directed as possible, that would be terrific. And also, this webinar will be recorded, and we'll have a shareable link that'll be provided after today's event. So. Our three panelists first is Dr. Chirstine Ritchie. Dr. Ritchie has joined us and is the Minaker Endowed Chair in Geriatric Medicine. She's Research Director in Division of Palliative Care and Geriatric Medicine, and also Director for the Center of Aging and Serious Illness at the Mongan Institute here at MGH. Joining Dr. Ritchie is Dr. Alexy Arauz Boudreau, who's an assistant professor of pediatrics at Harvard Medical School. And she's director for primary care and population health management at MassGeneral Hospitals for Children. And she's also medical director within the Mass General Hospital and the Mass General Physicians Organization, Medicare Accountable Care Organization. And Dr. Boudreau practices at the MGH Chelsea Healthcare Center. And our third panelist is Dr. Lee Schwamm. Lee is Vice President of Digital Health Virtual Care at the Mass General Brigham System. He's the C. Miller Fisher Endowed Chair of Vascular Neurology. And if you're seeing Lee on your screen, I think Dr. Fisher is over his right shoulder on the wall. Dr. Schwamm is also director for the Center for Telehealth here at Mass General and a professor of neurology at Harvard Medical School. So before we start the program, we continue to receive a number of questions about vaccine availability here at Mass General Hospital. If you've been following the news, a little over a week ago, the governor had announced that in an effort to speed up vaccinations, they were limiting the number of vaccine sites. And they're now sending vaccines to mass vaccination sites as well as to local pharmacies. But that change meant that no longer are vaccines going to individual hospitals or health systems like the MGH. Now, if any of you have received a first vaccine here or have an upcoming vaccine appointment at MGH, it's already been scheduled, those vaccinations will be honored. So we don't want you to worry about that. But you might have heard that companions that are accompanying those coming in for a vaccine are also eligible for vaccinations. Unfortunately, that is not going to be the case at MGH. Just those who have vaccination appointments will have their vaccinations delivered here at MGH. We are hopeful that this will change at some time in the future as the supply of vaccinations increase, but right now, going forward, there has been a pause in terms of vaccinations being available to MGH for delivery. And now it's my pleasure to turn things over to Dr. Ritchie.
Thank you, Dr. Nicholson. It's been a little over a year since COVID-19 entered into our consciousness and drastically changed our world. COVID-19 has now claimed close to 500,000 lives, American lives, and close to 2.5 million lives globally. And so it's been a dark year. But even in this difficult year, I will have to say that being at MGH has been a real privilege. As a new arrival to MGH in 2019, when I was working in the emergency department during the first surge and caring for older adults with serious illness, I was able to observe firsthand the courage, the commitment, and the compassion of my colleagues in the emergency department. And from the efforts of the MGH staff to check in on patients early on, and then of MGH to really make sure that their personnel and staff were maintaining their well-being, I couldn't be prouder of this MGH family. So as you heard in recent months, vaccines have given us a glimmer of hope for the future, and they have the opportunity to increase herd immunity and reduce the likelihood of serious complications for those receiving the vaccine. We're delighted that now close to 44 million Americans have received their first dose of COVID-19, and about 18.8 million Americans, around 5.7% of the entire population, are fully vaccinated according to the CDC. We hope that with expanded supply and weather-related disruptions abating, that we'll even see higher rates of vaccine delivery. And I hope many of you have already received your vaccine, but if not, know that those side effects of fever, fatigue, headache, and muscle aches are common and real and short-lived. And it does appear that those side effects are less pronounced the older we are. So according to the CDC, among those who received the vaccine between mid-December of last year and mid-January of this year, about 65% of those who were 50 or less experienced an adverse reaction. Around 25% of those people who were in the 50 to 64 range experienced an adverse reaction, and about 4% of those who were 65 to 74. Now, we don't know at this point if there's a correlation between reactogenicity and immunogenicity, but what has been very impressive across all of the vaccine trials to date is how effective this vaccination has been in older cohorts. We've all observed how COVID affects different people differently. Vaccine reactions are one example, but we've also read about a 21-year-old succumbing to COVID-19 and a 107-year-old Minnesotan woman surviving the COVID experience. And so it can be hard to predict how people will be affected by COVID. And while it is difficult to predict how any one person will do with COVID-19, we can say with certainty that those who live with dementia are more likely to do poorly with COVID-19, and that those who have dementia and who are people of color will fare even worse. So in a study that came out earlier this month of close to 62 million US adults, about twice as many people who had dementia experienced COVID than those who didn't, contracted COVID. And then if you looked at Black Americans, they were 3 times more likely, those Black Americans with dementia, to contract COVID than white Americans who had dementia. Regardless of race, people who have dementia and who contract COVID have a 3-fold higher mortality than those who don't have dementia. Now, there are likely many reasons for this increased risk for COVID-19 that we see in persons with dementia. The risk factors for dementia, such as cardiovascular disease, diabetes, obesity, and hypertension, are some of the same risk factors that we see for COVID-19 and for worse outcomes in COVID-19. We also know that dementia can interfere with a person's ability to adhere to things like effective mask wearing and hand hygiene. So that might explain some of the increased risks. But these aren't the only things that make it harder for persons living with dementia and their caregivers. Some of the most effective ways to manage behavioral symptoms in dementia involve familiar settings and familiar people. They involve closeness and touch. And these important approaches have evaporated for many persons with dementia because of visiting restrictions, because everyone looks and sounds different when they're wearing a mask, and because of the overall social isolation that many adults living with dementia experience, whether they're at a facility or at a home. And we have all seen the devastation of COVID-19 in nursing homes and assisted living facilities in particular, where close living quarters and COVID-19 positive staff or visitors have led to large outbreaks, and where visitor restrictions also lead to functional decline and social isolation. This situation has been very tough for caregivers. With fewer resources and people to help out and provide respite, and with fewer avenues for social connection or support, caregivers are facing a very high risk for burnout. Long distance caregivers face particular grief and loss as they are sometimes completely prevented from seeing their loved one, or they may find it difficult to regularly see their loved one in a facility or in a hospital. At MGH, we are conducting research to better understand the needs of caregivers who are caring for persons living with dementia. And what we've learned so far is that while a few say the level of strain is no different during this pandemic than otherwise, the majority describe accelerated decline on the part of their loved one during the pandemic. They described increased personal stressors and insufficient support from the community and from health systems. We're also partnering with researchers across the country to find better ways to care for people with dementia and their loved ones. And as a co-chair of an NIH-funded cooperative group, I'm also training investigators across the country to conduct better trials for people with advanced dementia. At MGH, our Dementia Care Collaborative has been seeking to be a source of real support to persons living with dementia during the pandemic and to their caregivers by educating patients and caregivers, healthcare providers, and the community. Throughout the pandemic, we have been delivering virtual health and resiliency sessions for caregivers that include movement, mindfulness, and motivational behaviors for persons with dementia. We offer educational offerings, and we offer regular caregiver support groups. We host a monthly forum called Conversations with Caregivers, which features a speaker with special expertise in a particular topic that's relevant to people living with dementia. Our overall goal is to support caregivers and people living with dementia to give them opportunity for increased joy, increased connection, and to reduce fear and isolation among those people during this very difficult time. We are really grateful to be supported to do this work at MGH, and we're seeking to expand our work so that it has a greater impact for more people in the community. Thank you for being a part of our MGH community. I'm looking forward to taking your questions during our question and answer time. And now I'd like to turn things over to my colleague, Dr. Arauz Boudreau, who's been caring for another vulnerable population, children, during this pandemic.
Thank you, Dr. Ritchie. Very nice to follow you. So we have come a long way in this pandemic. The thought that in less than a year, we would not only have a vaccine that's been distributed, but is also being given to the most vulnerable across the country is a great achievement of modern science. And frankly, I think as a society, as a global world, we got very lucky that the science was where it was when this disease presented. Now, the question, one of the main questions is what are these efforts in children for vaccination? And it's important to understand that the Pfizer vaccine was approved for children 16 and older, whereas the Moderna for those 18 and older. As you may understand, vaccine trials and any trials are usually started in the adult population, especially in an illness like COVID, where that's where most of the morbidity and mortality is. Children's immune responses are different and also different by their developmental stage. And given that the risk benefit ratio is different, given the decrease in mortality rate, we as a society took great cares to wait before enrolling children. Now, currently there are studies to understand how the vaccine works in younger populations. Pfizer has closed its enrollment period for those who are 12 and older, and they are expected to have results early summer. Moderna is still enrolling patients 12 and older, again, hoping to have results about their study in the summer. And many of the other vaccine products are also beginning to plan for childhood enrollment. Now, given the fact that the trials are still ongoing, the earliest we could expect anyone under the age of 16 to be vaccinated would be this fall. Although I suspect, given the massive vaccine efforts, it might be later. And for those under age 12, it probably isn't until next year that we'll be looking at that. Now, the other thing to understand about the vaccine trials for children is that they aren't being done to see if they are preventing disease like occurred in adults. And part of the reason is that kids just tend to get less sick from it. So you'd have to have vast numbers. However, what the studies are looking at, in addition to safety, is whether or not children mount an immune response. Now, many people are thinking, now that the vaccine is out, when can we gather again as a family? I know that it's a question I often talk about with my own mother, my mother-in-law, or close friends, like, who's vaccinated? Can we get together? And so many of us want to say that the answer is yes. But even though these vaccines are some of the most effective vaccines we have seen in our history, they are still only 95% effective. What that means is if 100 people are exposed to somebody with COVID, 5 of them will still contract COVID. It does seem to, the vaccines do seem to indicate that they protect from serious illness. However, depending on your own risk profile, serious illness could mean something different. The other thing is that we haven't yet proven that the vaccine prevents transmission. There's reason to be optimistic. For instance, in the Moderna trial, there does seem to be protection against asymptomatic infection, with only 0.3% of those in the placebo arm having contracted asymptomatic COVID after the first dose, and 0.1% in the vaccine group. And there's also good thought that those who have asymptomatic infection have less viral load and therefore may be less likely to transmit the illness. But we're far from proving that. So the question of whether or not I have a vaccine and now can I go have dinner with my family, the answer is a pretty tricky one. And I think in most cases, it depends on your own risk profile and what is that of the family you're visiting. For instance, there's good evidence that younger children, those under 10, are less likely to transmit illness than older adolescents. At the same time, if your younger child is playing hockey in sports or basketball, those are groups that tend to have more exposure and transmission, as opposed to a family that's been fairly isolated during this time and really keeping to that isolation. So there's multiple factors you want to weigh, in addition to whether or not you're vaccinated and what is your own risk tolerance and health history. Because unfortunately, even with vaccination, you still are at risk of contracting COVID. Now, the best thing you can do to prevent after getting the vaccine is to continue to remain masked when seeing folks. You can think about the fact that the arsenal of protective gear that we can wear for COVID has been increasing with the vaccine. Social distancing, number one, washing our hands, wearing a mask, and now a vaccine. Each of those adds an extra layer of protection. And if you continue to use those, you are more protected than if you stop doing some of those. Another question I get asked often is, what are the long-term effects of the pandemic on children and grandchildren? Now, there have been 3 million positive cases within the United States. About less than 2% of those cases are hospitalized, and less than 0.5% of those result in death. Much smaller than adult colleagues, but many would say still too much for any child. However, the real effects of COVID has been a mental health crisis in children. Isolation is difficult for anyone. And yet in adulthood, we have developed skills to help adapt to stressful times that children still haven't had the time to develop. Having said that, this is a time where we can teach our children to build resilience. And we do that by modeling for them how to respond in a stressful time, how to find the silver lining, how do you continue to connect with them and walk through this time versus completely sheltering and telling them nothing has happened. That idea that, it rains on everybody. And if we figure out how to use umbrellas, we can protect ourselves. Having those types of conversations with your children and grandchildren can be helpful for when the next stressful event comes. Now, a lot of these effects do differ by a child's age. You can think of babies who are still learning to read faces, right? When they're seeing your face masked all the time, they're going to become expert at reading eyes, but might miss some of those smile and other cues in the face. So you might want to consider doing Zooms with close-ups or wearing a mask that is see-through so that they can see your entire face. Toddlers will probably have heightened separation anxiety because they've been so close to their parents. So understanding that and coaxing them slowly if you're going to be spending time with them. Teenagers who typically are at an age where they're trying to understand who they are without their parents and gain independence can't really do that easily now. So as a grandparent, are there ways that you can offer them space and time to think about who they might want to be, who they feel like against their parent, without their parents, how are they interacting with some of their friends, if not in person? And then young adults who are trying to establish themselves in a world as chaotic as today are going to feel extra stress. So how do you talk to them in a way that they feel self-sufficient and bring perhaps past experience, your own past experience of going through hard times and becoming adults to help them through this? All this to say that regardless of what generation you're in or where you are in your stage of development, COVID has impacted your daily life. But together in community, be it virtual or at a 6-foot difference, we can really help each other through this time. My colleague Lee Schwamm will talk to you a little bit more about some of the work that MGH is doing in teletechnology to continue our ability to provide healthcare. Thank you.
Great, thanks, Alexy, and such a pleasure to be here with all of you. And thank you, Britt, and my other panelists. Look forward very much to the conversation that will follow after my remarks. So I think the first thing that I'd like to do is remind you that when we talk about virtual care or telehealth, we're talking about medical care provided through a variety of different avenues, one of which is Zoom. This kind of interaction, if you were the patient and I was the doctor, and we did our visit this way instead of being in the office. And I would normally ask for a show of hands, but of course I can't see your hands. But I'm sure many of you have had a visit like that with a doctor in the very recent past. So during the pandemic, most of our clinics basically were closed for in-person visits because of social distancing and what we didn't know about the virus. So virtual visits were like a lifesaver, literally. We functioned like a backup generator when the power grid failed. And the lights stayed on at Mass General and across the Mass General Brigham system because we had the foresight to invest in this technology and understand that it was going to be an important way to deliver care in the future. We were just experimenting with this kind of care, and only 0.6%, less than 1% of all of our outpatient care was being done over virtual video visits prior to the pandemic. And within 6 to 8 weeks, 62% of all of our visits. So we went from about 10,000 visits a year to 1.38 million visits in just the time from the middle of March to the end of September. Wow. And I will also say that the telephone was not left out, because some of our patients didn't have access to video or didn't really understand how to use a video device because maybe they had limited digital understanding, or they didn't speak English that well, or they had other things that we call social determinants of health. And so using the telephone to conduct regular visits with our patients was incredibly important, particularly for patients who had behavioral health needs. And our providers, our 10,000 providers, were incredible. They adopted this technology virtually overnight, and I couldn't be more proud of how our whole organization pivoted to respond to the crisis that was produced by COVID, both in person, as you've all read about in the newspapers, but also virtually. And I think it's remember how important it is and how we always are telling each of you, if you're a patient, don't delay or defer your care if you have a chronic health condition. You know, you need to get regular care. Well, that's true during COVID, just like it's true not during periods of time like COVID. And so the hospital is one of the safest places you can be. So make sure you speak to your doctor or provider to see if you need to be seen in person or over video to continue the care that you would normally be receiving. Don't wait until you're fully vaccinated to resume your healthcare. You've got to keep your healthcare going at all times. So how do we actually do telehealth? For those of you who haven't done a visit, virtual care uses several different platforms to support the video visits with your provider. And we leverage Epic, which is our electronic health record, to exchange information in the form of messages between you and your doctor or between doctors. Most of the visits take place using our health portal, which is called Partners Patient Gateway, now just Patient Gateway. And inside of that, Zoom, just like we're using today. But we also can do these visits using either Zoom or another product called Doximity as a standalone all by itself without the portal. Because while the portal is really helpful in helping us make sure that we get the right patient connected to the right provider, collect all the required information and permissions, other platforms still have to be available for our patients who struggle to make use of the Patient Gateway portal. Now, I will say we just did an upgrade of that portal yesterday, and you'll find a new, cleaner look and an easier use for that portal. Lastly, how do we think that telehealth, excuse me, innovation can create a more seamless process for you, the patient? Well, it's convenient, it's very patient-centered, and if you think about how much time and money you spend just getting to and from the doctor's office for a relatively short visit, surrounded by a long period of commuting, parking, lunch, waiting in line, etc., you spend most of your virtual visit with the provider directly. So we did a tremendous amount to make virtual visits easy and convenient for patients from their homes. We also launched a whole new line of services by creating specially configured iPads that we put at the bedside, so we could connect patients to providers, nurses, medical interpreters, their family members, and anyone they needed, especially when visiting hours and were restricted and patients were confined to strict isolation if they actually were infected. Many of our patients, the only time they saw a human face in full view, like Alexy was alluding to, was when the nurse connected with them over the bedside video to complete the initial intake and talk to them about their goals, about their healthcare history, and other things. So incredibly ironic, but important that the technology that we worry so much might dehumanize medicine was the most humanizing aspect of being admitted to the hospital with COVID during the beginning of the pandemic. And then what's ahead for the future? Well, the first is breaking down the barriers. We have to break down legal and regulatory barriers to make sure that virtual care is broadly available. We have to break down reimbursement and insurance barriers to make sure that payers reimburse for this service. And then the future is really bright to reconceptualize what it means to be cared for. And for now, we do a lot of what we call episodic care. You come to the doctor when you have symptoms, sometimes with an event like a heart attack or a stroke, and then we treat you. We would like to move to a model where we monitor your health continuously and intervene before you have a problem. So just like the warning lights in your car, they warn you before the engine fails. We want to monitor you and alert you before the next fall, the next heart attack, the next stroke, so we can prevent that from happening in the first place. So delighted to talk more about this with my colleagues. And at this point, I'll hand it off to my close colleague, Dr. Nicholson, who will take us into the Q&A.
Lee, thanks very much. And as usual, we've got a number of good questions that have come through the question and answer box. I'm going to direct this first one to you, Chirstine. There's a lot of anxiety for people who are living alone like hermits, safe from COVID, but not seeing friends or family. What resources are open to help people with extreme anxiety?
Great question. So there are a number of different types of resources. Certainly, I would encourage that person, if they have access to a healthcare provider, and especially a mental health care provider, to reach out and to actually try to get support through those channels. A lot of folks don't have access to a regular mental health provider, and in those instances, I would encourage them to use some of the mental health helplines. The National Mental Health organization has one, which I'm happy to post on the chat, a helpline. There's also a friendship line that can be used also for older adults, where they can call into a friendship line. These are volunteers who are trained in providing this kind of support. And then there are an array, happily, of a number of different kinds of resources out there online from reputable places that offer tools that can help reduce anxiety. There's the 10% Happier app, there's the Headspace app, there's the Calm app. And we know now, actually, from some clinical studies, that these different approaches towards mindfulness and reflection and quieting our spirit can also reduce anxiety.
Great. Well, thanks very much. This next question actually came in to me. It said, Dr. Nicholson, is MGH still developing a COVID vaccine? And if so, pending FDA approval, how will that be distributed? Well, the MGH is involved actually in two vaccine efforts. One that has received a lot of press. Dr. Dan Baruch at the Beth Israel Hospital is a faculty member at our Reagan Institute. And he's been intimately involved in the development of the Johnson & Johnson vaccine. The Johnson & Johnson vaccine is different than the Moderna and the Pfizer. Moderna and Pfizer uses messenger RNA, and the Johnson & Johnson vaccine uses what they call an adenovirus vector. It uses a safe virus as a way of sort of introducing the proteins into the immune system to generate a response. Johnson & Johnson has actually submitted to the FDA for permission for emergency use authorization, and that should be considered sometime within the next week. Usually the approval comes relatively quickly, and if that's the case, that vaccine could be shipped within 2 weeks or so. The advantage of the Johnson & Johnson vaccine is that it doesn't require the same cold storage that Moderna and Pfizer need, and it's also being marketed as a single vaccination as opposed to a dual vaccination. And then there's a second vaccine, which is a collaboration between the Mass Eye and Ear Infirmary, between the Perelman School of Medicine at University of Pennsylvania, and here at MGH, Dr. James Wilson at Pennsylvania, Luke Vandenberg at the Eye and Ear, and our own Mason Freeman are just completing enrollment and also a virus vector vaccine trial, which is probably several months away. But those are the two vaccines that MGH has been involved with that should be coming on to a market. So let's see here. So I'm going to direct this one over to you, Lee. It said, is it safe for individuals with multiple sclerosis to get the vaccine?
So this is a question that's actually come up with many of our patients with neurological illness. And the answer is, while we don't have detailed information about every individual neurological condition or rheumatological or immunological and how that might interact with the vaccine, we know for sure that getting COVID, if you have one of those diseases, can make your symptoms much, much worse. And the chances of having a reaction to the vaccine are so much smaller than the chances of getting COVID if you're exposed without vaccination that have reviewed this, and we are encouraging pretty much all of our patients to seek out and get vaccinated. The other thing to remember is this is not a virus. You're not getting virus when you get this vaccine. Unlike those of you who remember polio, where in the early days you got an attenuated version of the polio virus and you could actually get polio or give it to someone else from the vaccine. That's not how these mRNA vaccines work. So it's a great question. And we are preparing some information actually for some of our patients, if they do call, to ask whether or not the vaccine is safe for them. But I can tell you, speaking on behalf of the neurology department, don't hesitate. Sign up as soon as you can, wherever you can, to get your vaccine. And hopefully, those of you who are in Massachusetts, hopefully we'll start to see an increased distribution framework from the state as early as this week. And for those of you in other parts of the country, hopefully you'll have access to state-based care.
Great. This next one's for Dr. Boudreau. It says, I've read that the measles, mumps, rubella, or MMR vaccine may offer some protection against COVID-19 and may be some of the reason many children have a milder case. Is there any truth to this and any progress on the role MMR may play in COVID?
So there was a study that correlated MMR vaccination with lower rates of COVID-19 disease. However, it was just one study, and there were a couple of flaws in discussing it with our ID colleagues. For instance, infants who haven't been vaccinated with MMR vaccine also are showing a lower rate of illness. And then even after the first dose of MMR, you don't really build up titers. You do need that second dose at around age 4. And yet these children who don't have full titers are also protected. The other thing is that vaccination rates of MMR really does vary across the world. The US has particularly higher rates than the UK. And yet, regardless of MMR vaccination rates, children tend to be a pretty protected community. All this to say is that we need much more study to look at this to be able to say that there's any cross-reactivity between MMR and protection of COVID-19. And I would still strongly advise for a COVID-19 specific vaccine to help prevent transmission among children and from children to others in the community.
Dr. Ritchie, now here's a challenging one. What advice would you give to my 95-year-old father-in-law who lives with his daughter and me and who has been reluctant to get the vaccine to date and don't anticipate that he will change his mind?
That's a great question. And, you know, this may be one that you have to sort of chip away at over time, is my guess. You may just try to understand what's behind his worry and his concern. And it may take a while. It may take his seeing a lot of other folks get the vaccine and do well with it and have more freedom and independence for him to be willing to consider it. I think what is true is that if he doesn't get the vaccine, he will be much more constrained for much longer than he would otherwise be if he were to get the vaccine. And his likelihood to have more freedom and liberties would certainly increase if he were to get the vaccine. But this may be a longer term project if he's that ambivalent to begin with. I think the first thing is just finding out sort of what's contributing to his ambivalence. And if we can help you with answering some of those questions going forward, we'd be happy to.
That's a great answer. I'll have to use that myself with my patients. Lee, you highlighted in your comments around the telemedicine how telemedicine had the capability of making healthcare much more accessible. We've also heard that telemedicine may be increasing the digital divide between those who have access to computers and those that don't, or even those who have access to computers, the older population who may not be tech savvy. How would you answer that?
Oh, it's a very good question, and it's a very observant question. One of the challenges we face is that in restoring access to so many, we inadvertently excluded patients whose main method of reaching us had been coming in person. And I will tell you, we have a paper that's being reviewed at a journal right now that shows that unlike many other medical centers around the country who saw increasing disparity in patients who were from communities of color or who were much older, we actually preserved access for those patients to a greater degree than their younger, whiter counterparts, but predominantly through the telephone. We were fortunate in Massachusetts that the governor declared that virtual care needed to be paid for and that telephone care was reimbursed at the same rate as video-based care, which meant there was no disincentive for providers to reach out to their patients using the telephone instead of the video camera. But we have to be really honest with ourselves and recognize that COVID exposed what is a structural inequity in our healthcare system. I mean, Alexy lives this every day, managing the Medicaid population and our efforts to ensure that those patients have access to effective preventive care and treatments. And so we're working very hard. We actually have a grant that we've submitted to CRICO, which is our insurer for our malpractice insurer, to try to figure out better ways to engage our patients digitally, to increase the ease of use of these tools, and to think about alternative ways to reach our patients, text messaging, other kinds of interactive chat, ways that can be accessed without having to have a smartphone or a computer and a broadband connection at home. Many of our patients don't have that basic level of internet connectivity, and we have to be sensitive to that.
Thank you. Dr. Boudreau, here's one that I think you're probably best to answer. It says, regarding surface contact and hand washing, how much is sensible as opposed to how much is spastic? Can you be more specific?
So I think at the beginning of the pandemic, many of us were washing anything and everything that came into our house, leaving letters probably waiting for 3 days and washing every single grocery bag that might be delivered. We have learned that contact transmission plays less of an important role, but it's not necessarily zero. Now, contact transmission is through surfaces like letters or paper bags. Where we do see a lot of transmission is when you get the virus on your hands and touch your eyes or your mouth, both of which can be entry points in addition to those droplets. So hand washing is a really good idea to do it often and frequently, especially if you're outside, and trying to remember not to adjust your glasses if at all possible without doing some hand sanitizer is quite important.
Okay, thanks. Dr. Ritchie, one of the more painful realizations coming from the COVID-19 pandemic is understandably the restrictive visitor policies, but understanding also that dying from COVID-19 is particularly isolated and horrible. What's being done to more closely link dying COVID patients with family they cannot be with?
That's a really great question. It's been something we've been working on very seriously and aggressively at MGH. We have a very clear policy that people who are at the end of life can receive visitors in small, amounts at the end of life. That's very important to us that people have access to that. We also do everything that we can when people are not able to be close at hand to give them access through iPads and other tools to have that FaceTime with each other. But the best thing, of course, is being present. And that's been something we've been very committed to. Unfortunately, the challenge for many people is that hospital policies vary across the board around their commitment to supporting people at the end of life and supporting their loved ones in being with them. It's something that I would really encourage you to talk right at the beginning with hospital personnel about, to ask them what their policies are, and to make sure that they understand that you understand that this is generally and increasingly an expectation that people should be able to be with their loved ones at the end of life.
Well,
Britt, I would just like to follow on to Christine's comments that one of our most satisfying, successful, and embraced programs was something we called Patient Connect, which used that specially configured iPad and allowed the care teams on the floor to bring family members in to visit with loved ones who were sick, even if the loved one wasn't able to interact, to allow family members to visit with them, to talk with the team members about their care, and in some cases, make very difficult decisions about transitioning to a comfort-focused care when patients were in the intensive care unit on a ventilator doing poorly. So I agree with Christine. It's inhumane for patients to be dying alone. And we have to do everything in our power to make sure that families can be there with them in their time of need.
And maybe Lee, just to add to that, I think,
I don't know how to respond.
we've seen so many stories, heard so many stories of people across the country, across the world, being able to connect with their loved ones through that mechanism. So very grateful for that possibility and that approach.
Well, I wish we could go on. There are a number of wonderful questions still waiting to be answered, having to do with how long will the vaccine confer immunity? Are MGH staff required to get the vaccine? I have an allergy and carry an EpiPen. Is it safe for me to get the vaccine? I just want you to know that I'm going to give you an email address, which is mghevents@partners.org. So mghevents@partners.org. And if you care to, for those of you who ask those questions, if you'll submit them through that email, we will definitely get back to you. Again, I want to thank our panelists again. As usual, you were just terrific. And for everybody who's joined us today, I'm sure many of you who have already received the vaccine, but I cannot emphasize enough: wear your mask, appropriate hand hygiene, social distancing until Dr. Fauci gives us the all clear sign. So please be safe out there, and thanks for joining us. Bye-bye.